much for joining and giving us 1 hour of your time. We hope to be true to it. This is chapter 25 of the Bouncebacks Critical Care book, and I can't believe that we only have 5 chapters to go, and we started this in 2021. I knew that we'd bit off a lot, but we are chewing through it. And we have an excellent panel here tonight, who I'm going to introduce in just half a second. But first, to tell you a little bit about this case, this is a 51-year-old woman who presented with vertigo, and this is sort of the poster child for actually a lecture that I have given many times, which is called How to Spot the Well-Appearing Patient Who Will Soon Be Dead. And, you know, good job to all of us, emergency medicine, who are taking care of, you know, motor vehicle accident victims and STEMIs and you know, all kinds of like, you know, terrible large vessel occlusion strokes. But it's really the patient that can fool us is one that has the higher risk. And one person who I'm really glad that we have on our panel here is Eileen Chu. She is a risk management fellow working with Alma Mater at University of Maryland. And so we're actually going to talk not only about the medical aspects of this case, but some of the risk management aspects too. So before any further, I'll go ahead and introduce our panel, and I'll say, just to start things off, that no one has anything to disclose. Everyone who attends here will get 1 hour of free continuing medical education, which is a really nice opportunity. And thank you to Adena Health Systems for being able to provide that for all of us. So this is our Monday, first Monday of the month, Bouncebacks Book Club. This has been happening every month of the month except for in the summer. And actually, for the next 2 months, our next one's going to be in April, will be chapter 26. So we have nothing to disclose. I'll put this up here for a second here, so make sure that all of our ducks in a row as far as the free CME that folks will get. Here is the QR code to register for the CME credit, and I think folks have that. And towards the end, we'll flash the CME code to get your credit also. We have 4 people on our panel. We have Eileen Chu, who I've already introduced. We have Evie Marcolini, who folks have heard, I'm sure, many times on MRAP. And Evie is not only an emergency medicine physician, but also neurocritical care specialist. And in addition to that, and probably most importantly, a travel companion who invited me to come to Vietnam for a medical lecture in September, and it was amazing. And Evie, thank you so much for that. So I was really happy to get to know you better. And actually, the first time I met you in person at that conference. Karina Reyner is a emergency medicine physician and one of the chapter authors of this chapter that we're going to talk about, chapter 25. And Josh Russell is the editor-in-chief of Journal of Urgent Care Medicine, as well for the UCMAX podcast that goes with MRAP. So thank you all so much for giving your time for the teaching, the prep that you've done, and thank you to the folks who have joined to hear about this case. And this is an important case, a 51-year-old woman who presented to the emergency department with vertigo. And I will tell you, I like this case because it's neither obvious nor esoteric. It's a case that probably after you hear it, you'll say to yourself, I might have handled the case in the same way. And by thinking about that, to me, it feels like that is our opportunity. That's our opportunity to move from standard of care to excellence in care, because we can understand some of the subtleties of this case and some of the ways that not only we may have been able to make this patient safer, but also in some ways, and Eileen's going to share some of this with us, a way that maybe decrease some of the medical legal risk. Most importantly, improve patient safety, but decreasing some of the risk also. So with this one, we're going to start with the initial visit in the emergency department, and I'll just summarize it here. She presented on February 21st at 12:05, so just after noon, with a complaint of dizziness. And Evie's going to talk a little bit about the fact that she does not love the differentiation of vertigo and lightheadedness, and doesn't really feel like patients are typically able to tell us about that. But this patient talked about dizziness. She'd been feeling ill. She had some associated symptoms, nausea and vomiting, which is probably not that surprising. And she described her dizziness, at least per the person who took this history, as if the room was spinning. She says her symptoms are worse when she moves around, but no specific position that makes her symptoms more severe, which is sort of curious, but we'll talk about that more in a few minutes. In addition to the nausea, vomiting, she also has some diarrhea. You'll see her past medical history is pretty significant. Diabetes, she has a history of MI, hepatitis C. She does not smoke. She has, on her vital signs, a little bit of tachycardia. 112 is her heart rate. and other vital signs are pretty unremarkable. On the neuro exam, we'll just sort of jump to that right away. GCS of 15, no focal motor deficit, no focal sensory deficit. Vertigo symptoms are reproduced with the Dix-Hallpike maneuver. And I like how they do this here. We'll talk about this in a second here, but how they not only say it's reproduced with Dix-Hallpike, but they say actually what happens. Although we're going to talk probably a little bit with you, Evie, about some of that rotational nystagmus, whether they had that or not, and if that's important. But the patient did become diaphoretic during the maneuver. They did check some labs. We could talk about the utility of those. And they gave her antivert, and she was able to walk down the hall without difficulty. And she was diagnosed with benign paroxysmal positional vertigo, BPPV. So what I want to do first is, Karina, you as the chapter author, you get the first dibs at comments on this. Let's first talk about the data gathering, and specifically the bedside data gathering with the history and physical. What was done well, and what maybe could have been done a little bit better?
So I think, the most important thing for me when I'm talking to these patients, and I try to emphasize this really with my residents, is that you have to ask open-ended questions. And I agree that patients have a really hard time differentiating between dizziness and lightheadedness. So I usually don't ask them, would you say it's room spinning, or would you say you feel more lightheaded? I just ask them, what brought you in today? And as they describe their symptoms, I'll just say, tell me more. And I feel like if you don't guide the patient into a certain direction, then you're less likely to have an error. The things that I think are important, for me, it's incredibly important to assess for posterior circulation symptoms in all dizzy patients. And even if the patient tells you something initially that immediately sort of makes you think it's a peripheral cause, such as, dizziness with movement only, don't hang your hat on that. Pay particular attention to the duration of the dizziness, the timing, the triggers, because I think that this is really helpful to sort of narrow down your diagnosis. And then I would say that be systematic in all of these patients. So I like to assess for what I've read quite a bit about, the dangerous Ds. Does the patient have dizziness? Do they have diplopia? Do they have dysarthria, dysphagia? Do they describe dystaxia? Are they having difficulty with their, either truncal ataxia or gait? And I really like to ask family these questions as well. Like, what did you notice that was different? Because that collateral information can be really helpful. If you have any of those concerning dangerous Ds, then it really increases your pretest probability for a posterior circulation stroke. And the other things that I always consistently ask about are a headache. Describe the headache to me. If the patient has a new headache with a complaint of dizziness, I'm thinking of a cerebellar hemorrhage. I also ask about new neck pain because I think that you have to consider vertebral artery dissection in these patients. In this case, the diarrhea could have been a red herring. And I think if we fail to ask sort of our standardized questions for the sort of the red flags, I would say, of dizziness, then you may just assume that the dizziness in this case is due to hypovolemia or, a benign cause. So I think some things were done okay, but I think certainly you could, if you standardize your questions, you're more likely to pick up on some of those scarier symptoms.
It's funny, right? When you say that, it makes me think a little bit about like a primary complaint versus a secondary, right? So you could say the patient is vomiting and diarrhea, and then they have lightheadedness. Well, maybe it's from obviously hypovolemia, right? Dehydration. On the other hand, maybe they have vertigo, which is making them feel really nauseated and have vomiting. And hard to say where the diarrhea comes into my scenario there. But I love how you think about that. Man, if we could somehow like channel your brain into what the patients like when they come in, is like, my doctor didn't do anything. It's like, there's a lot of things that you thought through, when you're doing this assessment. So that's really, really helpful to think about. So Josh, the data gathering, we have some things done well, other things that we'd want to put in there. But what do you think about getting labs in the dizzy patient? I'm not saying right or wrong, but for example, the troponin, I know the patient has diabetes, we check the hemoglobin. What is your general process, and does it change at all based on the duration of symptoms when it comes to dizziness or even vertigo versus lightheadedness, if you do make that differentiation?
Sure. Well, I think that we want data, objective data, to guide us when there are non-specific presentations. So the tendency is to order tests for these, but unfortunately all these, other than the troponin, really are non-specific tests. So unfortunately, you end up in this situation if you're ordering non-specific tests for non-specific presentation, where either they're normal and you're falsely reassured, or they're abnormal and now you're distracted from what ultimately I don't know what was going on in this clinician's actual diagnostic reasoning, but what they documented was really not a clear differential diagnosis that they were working from. So the differential then should guide what sort of testing, whether that's physical exam maneuvers, history gathering, or objective testing like labs or imaging, that are going to be helpful for adjusting our post-test probability to either rule things in or rule things out. So the Bayesian thinking isn't really outlined there. And there, you mentioned like secondary phenomenon. This patient does have diabetes, so getting like a basic metabolic panel would be reasonable if the rationale was, I'm thinking about DKA, I'm thinking about hypoglycemia or hypokalemia from the vomiting and diarrhea. Those are all very reasonable. The troponin, especially in somebody who's got a headache and dizziness and no chest pain and a normal EKG, is not, I don't think you're raising to the testing threshold of even considering ACS for that. So it's not wrong, but I think maybe this takes the clinician's eye off the ball, saying like, oh, it's reassuring the troponin's normal, it's reassuring the EKG is normal. That's not really feeding diagnostic reasoning for what this patient has. So, and you talk about this a lot too, Mike, is like, if you're wanting to get to what the differential is, start with the problem list, and what is the problem list for this patient? There's vertigo, and we could talk about if it's truly intermittent or if it's persistent, because it's sort of not clearly delineated. There's vomiting and there's a headache. And then from there can flow a differential, whether you document that or not. Maybe Eileen can speak to the pros and cons of documenting a differential in these sort of situations. And then you make decisions based on that differential and pre-test probability of serious things. That is the lab going to alter that or not? And like a CBC, not really helpful at all in this presentation. But if there's slight abnormalities, it could be distracting, or if it's normal as it was here, it might be falsely reassuring. There are the GRACE 3 guidelines. I don't know if we're going to get into those later in this discussion. That's an acronym for Guidelines for Reasonable and Appropriate Care, written by Jonathan Edlow. If you're going to read anybody who talks about vertigo in emergency department presentations, I would recommend Jonathan Edlow. Him and David Newman-Toker are probably the godfathers of these statements, but they don't comment on labs, nor does ACEP have a policy, but the American Academy of Family Practice actually does have a policy statement saying that labs and imaging are not recommended if there's no neurologic abnormality found on examination. So I'm not going to, this is not a discussion of imaging, but they do specifically say an outpatient assessment, which we think about more in urgent care than emergency department, but labs really don't help for the assessment of vertigo.
Yeah, and I'm glad you mentioned Jonathan Edlow. He and I did an MRAP segment just a few months ago with a vertigo patient, and again, channeling his brain as well as yours and Karina's and all of ours here is just something that we could all learn from without a doubt, because he is, like you said, the grandfather of all this. So I'm going to ask you a quick follow-up question, just super quick. Dizziness, CAT scan of the brain, right? What do you think?
Well, that would fall into the same category as if you're not working from the differential and considering the test characteristics for the test that you're ordering, which CT non-contrast of the brain is very poorly sensitive for posterior circulation pathology, with the exception of hemorrhage, like cerebellar hemorrhage or brainstem hemorrhage. So that can be helpful if it's abnormal, but the common pitfall is the same with the labs, is that you're falsely reassured as a clinician that you have a normal test result when the real error in reasoning came from not understanding that you're ordering the wrong test for the things that could actually cause the patient's symptoms. So no to the non-con head CT. I mean, you do it as a screening test, it's fine, but it shouldn't really stop you if it's normal.
Yeah, totally agree. I mean, the things that you're looking for are not reliably seen on a non-contrast head CT, for sure. Okay, Evie, so next question to you is, and I sort of preempted this just a little bit before, you're not a big fan of this whole vertigo versus lightheadedness when we're thinking about dizziness. What's a better way to approach the symptom of dizziness?
Michael, you know why people don't like dizzy? Because there's so much to it. It can be anything. It's a very broad spectrum. So what I like to do is simplify it. So I agree with Karina. Stop with the lightheadedness versus room spinning, because it doesn't help us. It doesn't differentiate anything. It doesn't tell you where to go next. And the patients really don't know what you're talking about. They don't know how to answer that question. And there's a study that was done that showed that patients will answer it one way, and if you go back 10 minutes later, they answer it, 50% of them answer it a different way. We were all taught how to do this. Lightheadedness versus room spinning. We need to stop it. There's a new way to do this, and to simplify this. And I guarantee you, if you embrace this, you will love the dizzy patients. And it's just putting the patient's story into one of 3 boxes, and that's triggered episodic vestibular syndrome, or spontaneous episodic vestibular syndrome, or acute vestibular syndrome. So triggered means it's an episode of dizziness that's triggered. It's something triggered this. It's usually movement. And that's the patients we're talking about are the BPPV patients or any variation of that. And those patients, importantly, when they're not having the trigger, their symptoms resolve in between those triggers. If they're not moving their head, if they're not sitting up, if they're not standing up, they're not dizzy. Now they're gonna, if they've come to you with 3 days of this, then in between the triggers, they're gonna be kind of not feeling so great. But it's what you want to try to differentiate is the symptom happening when you're moving your head, and then does it resolve? That's triggered. The opposite, or the opposition to that, is acute vestibular syndrome. This is a patient whose symptoms are persistent. It's not stopping. It might get worse if I move my head, but it's not going away. It's persistent. So when you're evaluating that patient, they are having the symptoms when you're talking to them. And then the other one is the spontaneous episodic. These are the patients who say, something was going on. I had a guy yesterday, 30 minutes of dizziness while I was at the kitchen table eating breakfast. And then by the time EMS got there, it stopped. And so I'm in front of you, I am asymptomatic, and my exam is intact. So we can really get a lot of the way into this and do a lot of diagnosis just by trying to put people into these 3 boxes. And one of the most important parts of trying to do this is having intentional history taking. You have to know what you're going for. You can't just say, oh, what is your dizziness like? Does it stop and go? If the patient doesn't understand what you're looking for, you have to walk them through it. And so this is probably, I think, the most important part of it is intentional history taking. Know what you're going for and get the answers, and don't stop until you get them, because that's going to determine your next steps.
I've said many times, history is free. And you're
That's
at
right.
the website, why not get as much information as you can? Okay, Eileen, you've been so patient waiting for your turn. And I'm curious here because, you think that you have these like 20 pages of discharge instructions telling the patient, return with this, return with that, return with that, and they have a bad outcome. They were told to return, but they didn't. Does this help us medical legally? And how much of the discharge instructions that we give to the patient do they even understand?
I mean, in terms of mitigating risk, good ones can help you to a certain extent, but if you have a really poor outcome, really bad discharge instructions can kind of tank you. The time around discharge is really important. It's really the last interaction we have with the patient. I mean, hopefully. And it's important that we kind of know they know what's going on, and they know what the next steps are going to be and how they were cared for. So in an ideal world, everyone would understand their instructions and they'd be safely discharged and they live happily ever after. But there are studies that show that at least 78% of patients lack an understanding of their discharge instructions, and that's a lot. And only 20% of the time do these patients, recognize that they don't understand what is actually going on. So if we're going to give instructions, they have to be simple, they have to be individualized if possible. That means including a specific and achievable follow-up time, instructions for medications that they can use over the counter, medications that we're going to prescribe them, and definitely strict return precautions that are going to be specific to what you're concerned about, what symptoms they're having so far. And that also adds adds a layer of additional documentation that we can provide with them. Sometimes what I was taught was just that it might be helpful to include verbiage in your discharge instructions mentioning, as we discussed in the ED, blah, 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 to maybe jog their memory of the conversation that you actually had.
I love all that. And one little trick that I sometimes do is I'll put in my discharge instructions, as we discussed, return with this, whatever. And that's also my medical decision making. And I always feel like, you know, if it's a tie, some person remembers one thing, some person remembers something else. Well, you know, the more times that you can tell the patient is sort of like that, you know, tell them what you're going to tell them what you told them, then summarize it type of thing. So it's not for every single patient, but man, if you have a dizziness or vertigo type patient, however you want to call it, right? Well, for sure, these are the patients that it's not going to bite you too frequently, but when it does, if you're sending the patient out, you would just want to make sure that all of those roads are covered. So this patient, as you remember, presented on February 21st. She was sent home. And I do like the fact in the discharge re-examination, they actually said specifically vertebral basilar insufficiency was considered, that given that the patient's symptoms were easily reproducible on exam and there were no other neuro symptoms such as these things they mentioned here, dysarthria, diplopia, etc., that we think that vertigo is much more peripheral vertigo is much more likely. I will say a couple other things just to complete this section here real quick. We talked about headache. They did a pretty good job, gradual onset, so I'm glad that they actually put the onset. Oftentimes I've seen the medical legal cases that they don't actually put the onset at all, whether it's gradual or sudden. Mild diffuse headache. To me, it feels like some of the neuro symptoms we could have maybe gone into just a little bit more. I'm not sure it would have really helped necessarily, but I oftentimes ask any unilateral numbness or weakness of the extremities, blurred speech, facial droop, confusion, those types of things. Probably this patient would have answered no to all these. She was able to walk down the hall, etc. So in the end, that's why I like this case. You know, there were some things that could have been done to, again, move from standard of care to excellence in care, but, you know, pretty well done as the documentation. So before we go to the bounce back here, I'll just flash this real quickly. I don't think we need to have anyone to talk about this, but I can just sort of keep it on here. Usually anterior stroke symptoms, you know, numbness or weakness, confusion, trouble speaking, trouble seeing, walking, dizziness. That's probably with both, right? Sudden severe headache, and we think of maybe a, you know, subarachnoid hemorrhage of same as the patient that I saw just the other day who came in as a stroke alert, and I talked to the patient. And boy, it's not really common, at least from my experience, that a patient has a severe headache when they're having a stroke. But this patient had a really severe headache, and it started all of a sudden, and that was my concern. I walked back with her to the CT scanner, and that's exactly what we saw. She decompensated quickly, intubated her, and it was not a great thing for this patient, obviously. Now, typical symptoms of posterior stroke, boy, you look at here, and things are just a little bit more subtle, like dizziness, right? Half the time, but not all the time. But again, what is that dizziness? And maybe a patient can't really tell us necessarily about it. Double vision, we have headache in here, nystagmus, ataxia, dysarthria. But even sometimes you have those unilateral symptoms which you think more likely for the anterior stroke, and then that nausea, vomiting. So it's pretty easy to see how someone could be fooled in a patient who has resuscitation or room spinning, like this patient complained of, but they also have vertigo. And I've had patients say, yeah, it's worse when I turn my head and worse when I stand up. I'm like, okay, can you please be a little bit more like the textbook, right? So that's unfortunately not the way patients present. The patient did bounce back. I don't think that's any big surprise here. That's the title of our program here. She came back Wednesday, February 23rd, just a little shorter than 48 hours after her initial presentation. They were aware that she was there, presented 2 days ago for vertigo. She returned. She comes back by squad, got up to go to the bathroom at 4 a.m. and found that she couldn't walk. Now, interestingly, if you look at the time, this is 10:47 a.m. And I don't know, maybe Evie, you could invite us or enlighten us at some point. But man, oh man, you know, there are patients that they think they're having a stroke there at the ER in like 3 minutes, and other ones it's like, well, maybe I'll wait 6 hours and just see if I get better. And maybe I'd be one of those patients. I mean, who knows? So she couldn't walk. She fell to the floor, remained there until this morning, or maybe she didn't come in because she wasn't able to, right? When her friend arrived, they found her with slurred speech and left-sided weakness. and you see her vital signs are pretty similar than they were the day before. And they said the cerebellar exam was difficult to perform because of left-sided weakness. So let's just jump into some of our questions here. And as we go through the fourth of the Bounce Back books, the critical care book, it's a little bit of a different focus. The initial books, the first three books, really focus on that initial visit and what could have been done maybe to keep the patient safe or prevent a bounce back. But with this critical care book, the focus is on what we do once a patient does bounce back. In the critical care aspects, we think of a decision point, different options and questions that we answer in a literature-based fashion, what the clinician did, and then we move on to our next decision point. So here's decision point number 1. And we'll start with you, Karina. Again, we'll just do the same order with everybody. What are the most important aspects of the physical exam? History of physical exam to obtain immediately upon arrival of a patient who we think is having a stroke.
Yeah, so I think, for most emergency departments, this patient's going to probably come in as a stroke protocol. And I think, most emergency departments have that set up. And so what I usually do after having made this mistake many times is I usually tell families right away, I have to ask a lot of questions in a very short amount of time. And so if I cut you off, it's really because this is a time sensitive issue. And then I fire off my questions, because we all know that we've all been taught that time is brain, right, for acute stroke patients. And so that means we have to take a rapid history and perform a really quick physical exam before we put the patient in the scanner to look for an intracerebral hemorrhage. So the most important feature of the history for me is time of onset, because that really directs a lot of our therapies. Is this a TPA candidate or is this a thrombectomy candidate? And our data in the last 10 years has shown that patients can go to thrombectomy if they have an LVO up to 24 hours. And so that can be really challenging to delineate from patients and family members. And so I really try to focus on that early up front and ask the family, compared to the symptoms that the patient's having at this moment, when were they last, in their usual state of health? I think saying last known normal can be really challenging, because a lot of patients will tell you they haven't felt normal for quite some time. And then I go through my quick history. I ask about weakness, sensory symptoms. Have they had any, other stroke-like symptoms, aphasia, vision changes? I'll ask my dangerous Ds, especially in a patient who has ataxia. Ask about vertigo, oculomotor palsies, any diplopia, things like that, looking for my typical posterior circulation symptoms. And then I look for my stroke mimics. So do they have any constitutional symptoms, fever?
Talk about that
Was
yet.
there any...
We're gonna have Josh answer that. Talk about the stroke.
Okay. Okay, no worries. And then while I'm taking, no, that's okay. And so while I'm taking a history, getting to my exam, typically I'm checking the patient's pulse, making sure that they're not in AFib. That kind of can help me. First and foremost, you're assessing the airway. We're all ER physicians. Once I have confirmed that the patient has a stable airway, then essentially I'm moving to a quick neurologic exam. And you talked a little bit about, anterior versus posterior circulation stroke. A lot of emergency departments still depend on the NIH stroke scale. And I think we just have to remember that that's really geared towards patients who have an anterior circulation stroke. And so you have to be really cautious, because that's how you'll miss your posterior strokes if you just say, well, they had a reassuring NIH stroke scale. But, working through the exam, looking for strength, assessing all of your cranial nerves, especially, assessing for nystagmus. And if you're able to, looking for dysmetria, dystatokinesia, and then can you assess truncal ataxia? Sometimes it's hard to walk these patients, right? Because you want to get them to the scanner quickly. But those would be kind of the most important things for me up front. And again, depending on your institutional policy, it's important to understand that. But I always like to know what the patient's modified Rankin score is right off the bat, so I know kind of how aggressive I'm going to be. Because our neuroradiologists have certain criteria for who they take to thrombectomy. So those are kind of the things that I think of right off the bat, and then go from there.
Karina, a quick follow-up question. So say this is a pre-arrival stroke alert. Do you meet that patient in the hall, or do they go in a room?
We always meet those patients in the scanner.
Always. Right in the scanner then. Okay. So
Yep.
So hall/scanner, right? You're not taking them in a room first, because that's going to hold stuff up. So the assessment that you're talking about, is that done? I mean, do they automatically get a scan when the paramedics call the pre-arrival stroke alert, or do you do at least some type of assessment to make sure that the stroke mimics that Josh is going to talk about in a second are not occurring?
I think it's all kind of happening simultaneously, but essentially the patient's brought back. If their airway's stable, then we move them to a weighted bed, and I'm assessing them while we're checking for, checking their blood sugar, things like that. And then we're putting them in the scanner right away.
Gotcha. Okay, so Josh, now we've built this up quite a bit here, and Josh and I just recorded actually the intro to UC Max, and we talked about stroke mimics during that intro. And so, Josh, why don't you just go through some of those stroke mimics? Because, look, Eileen in a few minutes is going to talk about why maybe that doesn't make as big of a difference, but some of them are very obvious, right? I've had patients who are intoxicated with slurred speech and they come into a stroke alert, and clearly that's not a stroke, right? So why don't you just go through briefly some of the stroke mimics? I'll put some of those up on the screen that we've come up with.
Right, and I mean, Karina brings up an excellent point that the symptoms of posterior stroke and anterior stroke are quite different. So stroke mimics are going to be different depending on what type of stroke you're thinking about. And also, it wasn't mentioned in your slide, but we actually did a segment recently on a woman who came to urgent care with the posterior stroke, and headache is really common with the ischemic posterior strokes, like 30% of cases. So, which brings me to probably the most common among younger patients is migraine. And there are vestibular migraines, so people can have vertigo with their migraine. There are hemiplegic migraines, which is especially likely to be diagnosed as a stroke when it first occurs, the patient's first episode of that. And then seizure is the other very common mimic, and specifically like Todd's paralysis, where you have a hemiparesis after you've stopped seizing. And then even things like Bell's palsy can mimic a stroke. Hypoglycemia, always checking the glucose. This is thankfully protocolized now in patients as they come in, but something to always remember. And then they're particularly common now as we have older and more debilitated patients, many of whom have had prior strokes, is this phenomenon called post-stroke recrudescence, where patients are under stress, whether it be from sepsis, UTI, seen it with COVID, dehydration, GI bleed, and symptoms of prior strokes can be unmasked. So they may have mostly recovered from a stroke and then suddenly have pretty significant hemiparesis again. There are rarer things, transient global amnesia, things like maybe never heard of, but it's good to be aware of. There's a migraine variant called SMART, or stroke-like migraine attacks in patients after they've had radiation therapy. This can happen years after brain radiation. And then people can have PRES, hypertensive encephalopathy, transient symptoms in people with cerebral amyloid angiopathy. And then there's the things that we will find usually on the non-con, which is a mass or a bleed, and peripheral lesions can do it. But one of the more common things that we should probably, in all prudence, avoid is a conversion disorder, which ultimately is a diagnosis that many patients get when they come in with stroke symptoms, but shouldn't be something that we jump to obviously prematurely, and especially in patients who have no history of such. But it is important that in the TPA studies, and Evie might be talking about this, is about 10% of the time patients are thrombolyzed. They're found post treatment retrospectively to have had a stroke mimic. So even with the help of neurology consultation, advanced imaging, stroke mimics can look a lot like strokes pretty often.
Yeah, we're going to talk in just a few minutes. It's a really fascinating study by Steve Golis, who talked about the risk of thrombolysing a stroke mimic and what the true risk is. So Eileen's going to sort of go through that article in a few minutes here. So Evie, I want to nail you down on something, because in the past we've done some of these national programs with stroke, and you have talked about one of the big differentiators with dizziness or vertigo, right, or however you want to categorize it, right, would be constant versus intermittent. And the constant vertigo is something, the constant dizziness is something that makes us much more concerned. But, we see so many patients with dizziness. How do you differentiate, or how do you decide if you're going to call a stroke alert on a dizzy patient who has had symptoms less than 24 hours, but more than 4.5 hours, just to make it sort of easy? Do you find that you're calling those frequently, or are there some things that reassure you that it's not a stroke and enable you to not call a stroke on a patient you might, where there is still a consideration of a posterior circulation stroke?
So that's a multifaceted question, and
we're going to have you talk about that answer the rest of the program until 9 o'clock. Right.
What I want to say first is We haven't focused on posterior circulation stroke a lot, except in maybe the past 5 to 10 years. It's sort of getting more focused now, appropriately so, because younger people are having strokes. And younger people, when they have strokes, are having vertebral artery dissections. It's a bit of a crazy thing, and they don't have to have trauma to have a vertebral artery dissection. So the thing about this is thinking about posterior circulation stroke, and there are so many mimics, and you have to say, the mimic is not what I'm going to default to. It's after I prove that the patient's not having a stroke because of those mimics and because we miss the posterior strokes so often. So much more so than the anterior. I mean, the anterior, I guess we could think of it, it's kind of easy. Somebody has a motor dysfunction, a facial droop, etc. It's pretty bread and butter. But these posterior strokes are hard because there's so many mimics. Now, we tend to think about posterior stroke as, well, I got to think more about it. It's not as time sensitive, but that's not true. It's the same anatomy. It's a clot in the cerebral artery somewhere in the brain. It's very time sensitive. And Kesselman did a nice study in 2020. They looked at 13 studies in a meta-analysis, and they actually showed that IV thrombolysis for posterior strokes had a lower rate of parenchymal hematoma, a higher rate of a good modified Rankin score at the end of the day, and a better relative risk, and lower rates of death. So don't be afraid of giving thrombolysis to the posterior circulation stroke, which is my first message. And consider it the exact same thing as an anterior circulation stroke. And Karina mentioned that the NIH stroke scale, really, it's a research tool and it focuses on the anterior. You can have a posterior circulation stroke with an NIH of 0. And that's one of the more common mistakes to make is, oh, they have an NIH of 0, I'm not worried about stroke. But the other thing is, when you have a posterior stroke, it can be in the basilar artery. That's a hard one to discern because these patients can show up with intermittent stroke symptoms. If you have a dissection where the lumen narrows and a clot forms, and now you've got stroke symptoms, and then that clot breaks free and dissolves, now you don't have stroke symptoms and you look good. And then what's going on with that dissection? Maybe that lumen is going to have more clot that is still stuck to it. Intermittent stroke symptoms, think about a dissection. And then when somebody has a neuro symptoms that you can't explain, just please think about the basilar artery. Ask yourself, can this be a basilar artery stroke? Because if it is, you have a lot more time. That's why in our shop, we go out, we call stroke alerts up to 24 hours. And there are studies that looked at patients getting thrombectomy up to 48 hours and doing better, because it's a very low bar when you're saying somebody has a basilar artery stroke. That's a really poor prognosis. You can always do better. So endovascular folks will take those cases almost all the time because you cannot make them worse. You can only make them better. So, the message with the timeline is think about posterior stroke the same as anterior stroke, and think about that sudden onset and ask yourself, the last thing I'll say about this is the timing is so important, which is why I don't really care if you called something a stroke and it was a mimic, because it's so time sensitive. You have to work quickly, and that's what we do in emergency medicine. We work quickly with limited information, and that's why mimics get called strokes. That's okay. We don't mind over calling those. Send them to the CT, get a CT, get a CTA, and prove that it's not a clot. But don't err on the other side, because that's when the patients will get hurt.
Perfect. And we're going to go into that in a little bit. I want to just bring in a question. Andrew, one of the participants here, does the second presentation of this patient, the 51-year-old woman, she comes in with obvious stroke symptoms, but 2 days previous had the vertigo symptoms. Does this preclude the use of, and I won't even say lytics, I know you put that in your question, Andrew, but she was found at 4 a.m., got in at 10 whatever a.m. But does it preclude the use of endovascular therapy in the sense that now we think that she's been having symptoms for 48 hours? Or are you thinking maybe they're intermittent symptoms, she had a TAA, now is having a full stroke?
So when you have the patient's exam go back to normal, intact, you're resetting the clock.
Okay.
So
perfect.
so it's not really 48 hours.
Okay, awesome. All right, so next question here to Eileen.
Can I add one more thing to that for his question?
Of course, yeah, sure.
You could also just remember that you could always kind of partner with your neuroradiologist and get a CT perfusion study, which can tell you how much of the penumbra is still salvageable, which is really helpful.
Yeah, and so for centers that are able to do that perfusion study, I mean, that's sort of objectively then, I know there's some variation, and Sanjay and Mike on MRAP EMA talked about that recently, but at least it goes a little bit further objectively towards answering the question and breaking the tie. So Andrew, hopefully that answered the question you asked, which is an excellent question, but that resetting the clock is important to think about. So Eileen, I'm gonna have you answer this one very briefly because we're gonna have you answer a little bit longer the other two questions I'm asking. You can even just answer, within a few sentences if you want, but patients who might have renal dysfunction, they're over 50, they have diabetes, they have a history of chronic renal insufficiency, they're on dialysis. Do we delay the CTA in those patients?
The short answer is no, Mike. There's no absolute contraindication to getting this study done with contrast for these patients. It's a time-sensitive condition. It's emergent. Go ahead and get that contrasted study because if you get the non-con, then that's maybe insufficient for diagnosis, and that results in treatment delays and ultimately worse for the patient. If you're really worried, grab some fluids as you're on the way to the scanner.
Perfect. I love that answer. And this whole contrast-induced nephropathy, it needs to, let's just say that its time maybe has come. All right. So what had happened to the actual patient? Remember, she came in here at 10:47. She had a scan pretty quickly. Head scan came back negative, but shortly after returning from the study, she became significantly less responsive, developed sonorous respirations, pupil was less reactive, and she had a left-sided gaze. The decision was made to intubate, and the nurse asks which meds you're going to use. So when we're intubating a stroke patient, Evie, and I'm going to have you try to give this answer, we're going to give you like 60 seconds because we spend a lot of time, and excellent time, talking about some of this other stuff. But what are just some considerations you have and any of your favorite meds to use intubating a stroke patient?
Yeah. First of all, make sure that patient really does need to be intubated. We can always take a step back and say, this is a stroke patient. Are they protecting their airway? Because not every stroke patient needs to be intubated. Do a good neuro exam before you paralyze and sedate the patient. This is going to be invaluable down the line. Pay attention to blood pressure. The ischemic stroke patient is highly dependent on cerebral perfusion pressure, and you can have some fluids running, have an A line in place to monitor it in real time, and be ready with your push dose agents like phenylephrine. Have them ready in a syringe. Not I'm going to draw them up and give them, but have them ready to respond immediately to any drop in blood pressure, which you can probably anticipate. Pre-treat with fentanyl. I like to start with 50 to 100 mics, depending on the size of the patient. That's going to blunt the sympathetic response. And use the least blood pressure impacting agents. So etomidate is a really good agent to choose. It's blood pressure neutral compared to things like propofol, or even Versed that some folks use. You could think about ketamine because that's actually going to help your pressure to stay higher, unless you're hovering up near the 180, 185 and the patient got TPA. And then it's just a style point. Let everybody in the room know what you're doing and what you're thinking so that they can all keep an eye out on that and give specific roles to specific people by name. Mike, I want you to watch my oxygen saturation and call it out. Eileen, I want you to watch my blood pressure and call it out and tell me if it's getting over X amount or below X amount. So you've got everybody engaged in the process and it's a team effort. How's that for timing?
Love it. That was perfect. Yes. So I know you sort of talked about some of the agents. Karina, if you want to just very briefly, what are your favorite agents to use when? And I should mention also that number when patients come in, 220 over 120, a lot of people will be like, oh my God, that's so high, we need to lower that number. But that's sort of the number that we go up to, because that might be the blood pressure they need to sustain that perfusion pressure around that edematous area and make sure they perfuse at least the penumbra, right, of their brain. So it's a pretty high number that we can go to. All right, anyway, so Karina, if you want to just maybe even sort of very briefly, what are your favorite induction and sedation and paralytic agents?
Yep, I'll be really quick. I agree with what was just stated. Etamidate's a great option. Short acting, excellent hemodynamic profile. In terms of paralytics, you can choose between your depolarizing agent, succinylcholine, versus your non-depolarizing. I like succinylcholine. It's rapid onset, short duration of action. And so when the neurologist comes down to see the patient, sometimes if they'll ask to hold sedation, they can get their own exam. So for me, I think it's when I was in residency, they taught us that you had this transient increase in ICP if you use succinylcholine, but I don't think this effect has been shown to be clinically significant. So I stuck with it, and seems to work well.
I used Sux for like the first half of my career, never had a problem. Etamidate second half, never had a problem. So yeah, I think we're in good stead either way. All right, so Josh, this drop in the blood pressure that Evie was talking about before, and again, just sort of briefly, because I want to spend a little extra time on some of the stuff Eileen's going to talk about in a few minutes here, because I think it's going to be super interesting to all of us. But do you specifically have agents at the bedside, whether phenylephrine or epi, to make sure the blood pressure stays adequate during your intubation? And we talked earlier about Alan Hefferner, and who Karina had worked with, and Evie knows, and I know. And one of his really seminal studies talked about the fact that if you have post-intubation hypotension, or a post-intubation arrest, specifically, it's like the mortality is like 82% for that. So, definitely want to make sure that the most intensive of procedures that we do, that we can potentially control something that might happen, like a drop in the blood pressure. So how do you specifically do that? And do you do anything to account for the fact that the blood pressure could drop with those induction agents?
I couldn't agree more with what Evie said about, first of all, asking the question, is intubation like 100% clinically indicated at this moment, especially if you are dealing with the airway pre-imaging and you're not sure if you're dealing with a hemorrhage or an ischemic situation. As you mentioned, the AHA-ASA guidelines for permissive hypertension go up to 220 over 120. So whereas if you're dealing with a hemorrhage, you want to be thinking about the blood pressure management entirely differently. So if you can forestall intubation until you have that imaging to know what kind of stroke you're dealing with, that is really helpful. Nicardipine is usually the one that's most readily available if you're dealing with the blood pressure being too high. I would say that is rarely the case. Blood pressure dropping to a level where it's what we would think of as low is also pretty rare, but phenylephrine, or I personally find push dose epi a little bit easier to acquire rapidly, but I'll have that on hand. And occasionally, if it's dropping into like the sub 140 systolic range, maybe give 10 or 20 micrograms, and that's usually just right after intubation, making sure the fluids are running. And then you also just want to make sure the more critical things are like avoiding hypoxemia and making sure that patient's adequately pre-oxygenated with high flow nasal cannula, and that the laryngoscopy time is minimal because that can spike the blood pressure as well. So you want the most skilled operator intubating, those kind of considerations.
Awesome. So, I had oftentimes thought, since the first NINS came out in 1995, well, 6% symptomatic hemorrhage with TPA, 12% asymptomatic hemorrhage, and as Kevin Clower once said, asymptomatic hemorrhage in your brain is still a pretty bad day. So I had come across this study then by Steve Goulis, I think that's how you say his name, Steve Goulis, and I was just fascinated by this. And they looked at patients with stroke mimics who are thrombolyzed, and Eileen, they didn't really find a whole lot of problems.
No, they didn't. You and Josh already kind of alluded to this, but the risk of thrombolysis in these stroke mimic patients is generally low, so it's still considered acceptable to give these patients TPA. They had much lower rates of intracranial hemorrhage when they're compared to the other patients who had acute ischemic strokes, and they left with that diagnosis. So if you do end up getting caught like TPAing a stroke mimic, like at least you have some reassurance that you'll be okay, and the patient will be okay.
Okay. And what was explained to me, Evie, you could correct me later if I'm wrong on this, but patients who have a stroke mimic, to me anyway, I think of it like some of those earlier, for the gray hairs in the room, the earlier studies when we looked at thrombolytics for STEMI, we found about a 0.9% hemorrhage rate, now not just intracranial, but any type of hemorrhage. Well, the reason why the NINS showed such a higher rate of hemorrhage with strokes is because, you have now damage here. You have ischemia, you have some edema, and that area is more likely to bleed than a patient that is having, for example, conversion disorder or a hemiplegic migraine, as Josh was talking about. So what happened with our patient? We got more history from the boyfriend after the patient's intubated. The patient had been feeling well, but did complain of some dizziness, no definite ataxia. So however helpful that is or whatever, they intubated the patient using succinylcholine, interesting, and etomidate, and endotracheal tube position was confirmed. So we have about 9 minutes left. I want to make sure that we're true to things, and I want to get to this legal issue, question number 3. But Evie, I'm going to sort of skip by your question just for a second here, if that's okay, because I think your last one was fairly similar. But then we'll give you an opportunity after we talk about this decision point C, and I say what happened to the patient. If there's other things you want to add, and we'll have an opportunity to summarize things later. But if you could just, Karina, give us like literally a 30-second difference in blood pressure goals for hemorrhage patients versus stroke patients, that'd be helpful.
Yes, I'm happy to. So blood pressure control in ICH patients has been kind of the focus of several randomized control trials. The INTERACT and ATTACH trials are the two big ones where we get our data from. And basically, they showed the safety of lowering blood pressure to less than 140 systolic in patients with an intracerebral hemorrhage. So based on the results of these studies, what they found is that outcomes are not better whether or not you lower it to less than 180 or less than 140. So it depends on, it's institutionally dependent. Our institution likes to keep the blood pressure less than 140, but the AHA guidelines say under 180 is basically desired to mitigate the risk of hematoma expansion. And sometimes that's confusing because, as you mentioned before, in an ischemic stroke as opposed to a hemorrhagic stroke, the goal is to basically, keep your blood pressure elevated to increase your cerebral perfusion pressure to that penumbra. So ischemic stroke, you don't want to go above 220 systolic, but in your hemorrhagic stroke, you want to slowly lower it to prevent hematoma expansion.
And the only thing I'd add to that, and something I see people sometimes forget, is thinking about things like prothrombin complex concentrate for patients, who have hemorrhage, who are anticoagulated, specifically with warfarin. Okay, so Eileen, I've been building you up for this part here. Some of my favorite studies here by Hazlitt and Qureshi. So is it legally riskier to, Evie, you're smiling, to give a patient thrombolytics who's having a stroke mimic, or to not give a patient thrombolytics who was potentially within that window?
I mean, there's definitely always going to be a fear that if you give tenecteplase or TPA and your patient suffers a bleed, that you're going to be sued. But in this review article by Hazlitt that you kind of mentioned already, they had 246 cases, and most of these cases revolved around a failure to diagnose stroke and a failure to treat with TPA or thrombectomy in a timely fashion. That review also found that if you have a failure to get a neurologist involved a little bit more quickly, then it also kind of resulted in a case, and that was at least 22% of those cases here. All in all, though, it looked like about 56% of these cases favored the defendant, and also if you had a neurologist on board, you were more likely to get a favorable verdict. But the fact is, most of these malpractice claims are going to result around not giving TPA or not getting thrombectomy, and that being in a timely fashion.
And this was the Hazlitt study was more with systemic thrombolytics, whereas the Qureshi studies was interventional, and really found very similar sort of findings, that it's riskier not to do than to do. And for folks who have the benefit of having a stroke neurologist that can come on either on site or with a robot, well, that's a little bit easier. You don't really have to make that decision, but our decision then really is whether to even initiate a look for a stroke in those sort of patients. So Josh, very quickly, you have not only emergency medicine, but also palliative care. And we have this patient here, we've intubated her, and boy, she wasn't doing that great before intubation. Is it time to have an end-of-life discussion? But I'd like you to see if you could do this in about 30 seconds or less.
Are you talking about an end-of-life discussion, or they answered the question?
Both.
So it's funny, my capstone project was actually creating a video for educating patients about when I was doing my fellowship about the importance of surrogate decision-making and prospectively having that for when some situation like this comes up. But it's a really tough situation, right? Because you can't involve the patient in the discussion. But while it is true that the outcome of strokes is not fully determined for about 6 months and maybe even a little bit longer, the initial NIH stroke scale does do a pretty good job of predicting 3-month and 6-month modified ranking scores. And so if you have a NIS of less than 5, that's very strongly associated with being able to be discharged home. The middle of the road, 6 to 13, is likely going to need short-term rehab. Over 13 is a good number to remember. These are patients that almost never are going to be able to live independently. So having a little bit of understanding of how we can prognosticate an acute strokes outcome down the road is useful to share with families, especially if they're open to receiving that information. Intubation is a bad thing. If you're intubated in an acute stroke, you have about 50 to 75% 30-day mortality. There are scores. The Thrive score is one that does involve some imaging characteristics, but that's been pretty well validated. You can find that on whatever clinical calculator you like to use, but that can give you a sense of what the patient's outcomes are going to be. But I would say that from a palliative care perspective, it's never too soon to start that process of thinking about these things. So you don't have to have all the answers, but this is somebody who was relatively young and healthy recently, and whoever is the surrogate decision maker is going to take time to process that they're not going to get better. So the sooner you can plant the seed that this person is probably not going to be able to live independently, and start to even ascertain what this person's preferences may have been if they were ever communicated, and who that surrogate decision maker will be, that really sets up and Evie can talk about this as, the ICU team being set up with even just those basics,
right.
is really helpful. So you don't have to sit down and have an hour conversation, but just planting that seed so that even if they're not ready to accept the fact that this person may not survive this, and the most sensible thing based on their preferences is to withdraw life support. If you plant that
expectations are so important, right?
Yeah, if you plant that seed on day 0, then that seed can be germinated on day 3 instead of it being planted on day 2 or 3, and then it takes until a week or 2 weeks down the road for the family to finally come to terms with their prognosis and agree to withdraw the life support.
Yeah, and that's actually what happened with this patient. She was evaluated by neurology. She was not deemed a candidate for thrombolytics, obviously. She was found to have a brainstem infarct, support was withdrawn, and the patient expired later that day. So I'm going to flash up here the QR code for folks to get their CME, and I've been waiting for all of that. We are at about 2 minutes till the hour. And so what I was going to ask, and I'll put the code back up here in 2 seconds here, some take-home points. Think about post-circulation strokes. Don't delay imaging for a stroke scale to be done. And all of us are doing either in the hallway or in the CT scanner evaluations, which can be done obviously without even knowing their renal function. And then what Eileen talked about with the Hazlitt study was really important. So let's sort of go down the list here, 30 seconds each, true 30 seconds. Eileen Chu, and I'll put the QR code back up here again. Eileen, if you want to give us a 30-second thing that you want folks to take home after they hear this program.
Be aware of your dizzy patients, whatever that means for them, and don't delay anything just due to a fear of complication. Get them to the scanner, do right by the patient, and get them treated.
Awesome. Evie, what are your take-home points that you want people to go home with?
Don't shy away from the neuro exam or the dizzy patient. Embrace that, because it's bread and butter. You're not going to get into trouble if you do the bread and butter things. You don't have to be an expert on the HINTS exam. You have to just ask good questions, do intentional history taking, and walk the patient through the questions. If you don't know when it started, let's go back to when you woke up this morning. When you opened your eyes, were you having the symptoms? Then when you got up, what happened? And walk them through it. Respect the onset of anything. Anything that has a sudden onset, think about stroke. Anything, all right? And if you just do one thing is approach this patient from the perspective of the vestibular syndromes, you're going to make a ton of headway, and you're going to catch patients that you would not have.
Love it. Okay, Karina, what are your take-home points you want people to take home?
I'll give the take-home point. One of them is something I tell my children: you have 2 ears and 1 mouth, so listen before you speak. The history is the most important part of medicine, and I feel like it's a lost art. Do as my chair, Mike Gibbs, told me to do, which is pick up the chief complaints that make you uncomfortable, so that when you're an attending, you're not uncomfortable. And when you ask a patient to walk, don't order that. Don't make that a nursing order. Physically get the patient up and walk them yourself. And that's how you can truly assess for ataxia and not miss it.
I love that we're all here saying that it's the history in the exam. That's where we're getting a lot of our information for whether we even start this pathway, right? Because we have to get that data to decide whether you even want to think that it could be in the differential stroke. Okay, all right, Josh, 30-second take-home point.
So we didn't really discuss this, but one thing I think that may have led the first clinician to some reassurance that was probably false was doing a Dix-Hallpike exam. And so BPPV, as we're getting into aspect of history, is really a historical diagnosis. And the Dix-Hallpike doesn't have great test characteristics. It's about 75 to 80% sensitive and specific. And like those labs that can be falsely reassuring when they're not really indicated for this, a Dix-Hallpike that is provoking dizziness, especially in these acute vestibular syndromes, if you're going to do it, it should be people that are clearly having intermittent vertigo. If it's not clearly intermittent vertigo, it's going to make everybody with acute vestibular syndrome worse and more vertiginous if you're turning their head around. So it takes some time. It's not a great test, so I steer away from that. And the same thing about listening to the history is listen to the family if you're having end-of-life discussions. It will tell you things. So if you're doing most of the talking in a goals of care, even if it's a brief conversation, that's not how it should work. It should be you listening to what that patient, who that patient is as a person and what they might want, because that's going to inform the care down the road.
Love it. Thank you all so much for taking an hour of your life and joining us. And I hope we were true to that. I myself learned quite a bit from this really amazing panel. So Eileen and Evie and Karina and Josh, thank you all so much for that. Our next book club is on actually April, the first Monday in April, April 7th. You can always register at the website EM, like emergency medicine, embouncebacks.com. As well, you can see all of the old videos from the first 25, actually not the first one, but 24 of the first 25 that we have done. And there's, so many of the really famous emergency medicine physicians that you can hear in these programs here. Here's the QR code to register. And I hope everyone has a great night. Again, thank to everyone for joining, and thank you so much to the panel for your preparation and your expertise.
Thanks, Mike.
Thanks.
Thanks, Mike.